Ali, and at the outset, I must confess that whatever little I know of retina, I thank the technology that was made available to us by our teachers in late 70s and early 80s, and ever since in the last 15 years, the digital technology became available. Earlier we had the film-based technology, and that was a little cumbersome, but almost like 15 years, digital technology for imaging is all pervasive, available everywhere, and I think this has been the greatest advantage, not only in patient counseling, but for your own education and learning. So what I'm going to be talking about is, do these technologies have advantage over each one, or are they complementary? So at the end of the talk, perhaps you'll be able to see Now, I think after a beautiful introduction by Professor Gupta, let me tell you that lipofuscin is deposited in the RP cells. It's a byproduct of the outer segment of the photoreceptors, which are round the clock being phagocytosed by the RP cells, and they have no mechanism to extrude these lipofuscin. Now, lipofuscin is a material which is autofluorescent. When I say autofluorescent, means that you stimulate with the shorter wavelength, it emits light in the higher wavelength. So that's the basic principle, and that's what you are seeing here. That there is a natural fluorescence, like what you see here in a young person, and this is what you see, a diffuse fluorescence. This is coming from the lipofuscin in the RPE. But the vessels appear dark, the optic disc appears dark, and since the blue light, this is a blue light fluorescence, autofluorescence, blue light is absorbed by the luteal pigments in the central macula, so you see it dark. But if you did the near infrared autofluorescence, that's another technique to elicit the same thing from probably different fluorophores, mostly the pigment. The center of the macula is little more hyper autofluorescence. Now, to briefly tell you that there could be two things. Either fluorescence could be decreased or it could be increased. So we talk in terms of reduced fluorescence. Obviously, if there is RP atrophy or there is no RPE, there will be no fluorescence from the lipofuscin. Or if there is excessive lipofuscin, it will show a more fluorescence. So I'll give you some of the examples like this one. I mean, you might, in a busy clinic, you might miss out on this RP rip, but since the RP is not present in this area, so you see this hypo or decreased fluorescence, and this is the rolled over margin of the scrolled margin of the rip, and here, since it is reduplicated, you are seeing increased fluorescence from the rolled over margin of the RPE. So this just to give you an idea. Now, some of these patients who present to you with some kind of disc swelling and typically would be referred from the neurologist, with papilledema, but you put them on the autofluorescence, which is a non-invasive technique, and you see that there are budded drusen's accounting for this kind of disc edema. Or a patient like this, again, you don't know what's going on. The patient is symptomatic. The fundus photography here is not telling you anything great. But the moment you do an autofluorescence image, you see there is areas of geographic atrophy. There's so much atrophy going on. There are increased autofluorescence areas, which are the ones when they increase, it means this RP cell is going to burst open and going to die. So we know that these are the areas which are next to go and become hypoautofluorescent. You must know that wherever there is no RPE, the photoreceptors overlying that RPE area are also dead. So these dark areas indicate the dead areas in the retina which are non-functional. Now this is a very interesting, and Geeta mentioned, one of the major indications. Like this patient, we had been following this lady and doing a fluorescent angiogram. We thought, well, this is some kind of occult membrane. It is getting hyperautofluorescent, and we kept on injecting, bevacizumab because that had become available. And there was no change. Okay, and then something like about 6 years ago, we got access to autofluorescence first time in this country, and lo and behold, this, which had now changed shape, And when we put it on this, we knew that there is a excessive accumulation of lipofuscin, and these are the adult onset foveomacular vertiliform dystrophy or degeneration, which are lipofuscinosis as we call, and doesn't require any treatment. At the moment there is no treatment for this. So we were unnecessarily giving those kind of injections. So it gave us vital inputs into this. Now these are some of the chorioretinal scars. You might do microperimetry to do the, to assess the function in these areas, but we know the moment we do the autofluorescence, we know all these black areas are dead areas. Or as she rightly mentioned, that this is a tool being used all over the world now to monitor the progress of geographic atrophy or the development of geographic atrophy. Here's a guy who's been being treated for several years now for wet AMD with monthly injections of anti-VEGF agents. And you can see at this point of time he was seeing about 6/9 vision, and there is a small tiny area of geographic atrophy which is developing, and over a period of he is losing vision, and we know till autofluorescence became available, we couldn't tell. He was symptomatic. He's saying, I'm losing vision. The moment the autofluorescence images became available, we now know that his area of geographic atrophy is progressing, and that's accounting for the loss of vision. There's another interesting lady with a large PED, there's a lot of exudation, there's a CNV, and duly received a Western injection. This is the end-phase which she was talking about, the end-phase OCT. You are cutting like a onion peel, and this is the PED, very nicely demonstrated in the RP-FIT image of the, and we gave her a Western injection. Now there's increase in exudation, and there is a, we don't know what's going on here, but apparently there's some kind of altered blood there, and you see some kind of a scar here. You're not able to make up your mind what all is going on. And on the OCT, now we find the same edge, which was absolutely regular in the end-phase OCT. There is a adhesion here in the RPE. Okay, but you've got to be very, very smart to detect these changes on end-phase OCT. Most of us are not as smart, so we do the autofluorescence image, which in an instant tells you what it is. This is the rip here. Okay, and all this increased autofluorescence because of the altered blood which is present. Remember, the red blood gives you hyper, it absorbs all the blue light, doesn't emit anything. Okay, so it will give you a dark picture, but when it alters, loses hemoglobin and turns yellow, it becomes autofluorescent. This dead RBCs are autofluorescent. And we followed this patient, and you can see the progression of this rip as it progressed over the next several months. We have been using this technique of imaging, and this is a great tool. Actually, in the long time back, we used to draw diagrams, and we used to, keep spending so much time trying to draw those diagrams. With the digital technology, now it's possible. You want to know exactly what's happening to the patient, okay? And you could take the pictures, and right there on your screen, you could see, go back to the images in the past and see whether the disease is progressing, regressing. Here is an example of a serpiginous choroiditis. You can see from over a period of 1.5 years, the lesions have progressed. But still you can't say which lesion, where it's going to progress. Okay, so information is incomplete. So you go to autofluorescence, and we know that these hyperautofluorescent areas are the ones where the lesions are progressing next. So you could be telling the patient whether your lesions have healed or progressing. And here is the fundus autofluorescence serpiginous multifocal serpiginous choroiditis, and you can see the active lesions here. You can see the lesions as they start healing, they acquire a hypo ring, and then they become mixed fluorescence, and you could actually follow them up on autofluorescence. The image may not be telling you much, and it's likewise, you can follow them up. Here the fundus imaging doesn't tell you whether the lesions are active or healing, and on autofluorescence you can immediately make out that the lesions are actually healing very well. Just coming briefly to the OCT, you all, I'm sure, all of you are exposed to OCT, you know what are the conventional roles. I'm going to be talking about a little bit of the the newer applications, and this is based on EDI or enhanced depth imaging of the choroid. Now I'll give you an example of this guy, who's sympathetic ophthalmia, and he had been receiving immunosuppressive therapy for years. He became symptomatic one day. I stopped his immunosuppressive a month ago, and he came back. I'm blurring of vision. I saw vision acuity is good. His nose flared, no cells, no activity. Okay, and we did the EDI, and there you can see the choroid is thickened. I said, my God, he's got a recurrence of sympathetic ophthalmia because there is a choroidal thickness. So we put him on steroids, and lo, what is happening now? Immediately the choroidal thickness starts decreasing, went down further. So now we know he had a recurrence of sympathetic ophthalmia, first manifesting as diffuse choroidal thickness, and is responding to a treatment. Another young lady, now this is a very, very challenging patient, had multifocal small choroiditis lesions, was treated on corticosteroids, and you can see these lesions are actually increasing with our treatment. So this is some wide angle. I'm sure Vishal is going to talk on these, but you can see these lesions are progressing, and autofluorescence is also showing that these lesions are actually progressing. These black areas are the healed patches. And now, she had some evidence of tuberculosis, and we said, since your lesions are increasing, we'll put you on anti-TB drugs. Okay, and we followed, and we found that, well, the lesions actually were threatening now the fovea. Okay, these are the autofluorescent images, and and we said we are going to hike the steroids to control, because she was going to go blind as a young woman and a lawyer on top. So this is what I've shown you on fundus image and on autofluorescence. Now you see the drama that unfolded on the EDI or enhanced depth imaging. This is just before she started worsening, and this is where you can see how the choroid keeps on getting thicker, and then we enhance the corticosteroids and it starts coming down. It starts decreasing and still further down. So we are happy that she is now responding to our treatment. So monitoring response to therapy or seeing the occurrence of a pathology particularly in the choroid, I think this is a great tool. Likewise, the sarcoid granuloma, you can hardly make out anything in the fundus image, which is seen somewhat better on fluorescent angiogram, but you can monitor these, like this is the granuloma sitting here. On treatment, this is disappearing. You can monitor this. Okay, or like vitreoretinal lymphoma have very, very classic appearance on deposits on OCT. Or this is a patient whom I operated, and intraoperatively I thought, well, this looks like a lymphoma. Okay, is it lymphoma? Should I go and do a retinal biopsy to prove that this is lymphoma or not? So before doing that, I thought, let's do the EDI. And what does EDI show? It shows that these are not lymphoma deposits, but these are the choroidal granulomas right there. So what I have demonstrated is that most of these tools, imaging tools, are complementary to each other. And as the technologies evolve, as Professor Geeta has very rightly said, it's going to add to our armamentarium. These are not exclusive of each other. We are not going to do away with our fluorescent angiogram or fundus imaging, but they are going to give us more and more information. And thank you very much for your kind attention.